We are heading into the abdomen to talk about the large intestine.
It is a journey into the final frontier of digestion. And I know usually when people think about the gut, they think about the stomach turning food or, the small intestine absorbing all the nutrients.
Right, and the large intestine gets relegated to, well, the plumbing.
The waste chute.
The waste chute, yeah. You think of it as just the pipe that takes the trash out.
Oh.
But looking at these sources, specifically Chapter-65, that description is a massive undersell.
Oh, it is a huge undersell. If the small intestine is the factory floor where the raw assembly happens, the large intestine is the quality control, water reclamation, and packaging department.
I like that.
It is an engineering marvel of valves, pressure gradients, intricate reflexes, and specialized immunity.
It's the final edit, if you will.
Exactly. It takes liquid chyme, which is essentially a slurry of food and digestive juices, and over the course of about 1.5 meters, transforms it into something solid and manageable.
It's incredible.
And the mechanics of how it does that, how it moves things against gravity, how it knows when to hold and when to let go, it's genuinely fascinating.
So our mission today is to demystify this tube. We're going to walk the entire path from the blind pouch of the cecum all the way to the anal canal. And we're going to look at the clinical side, too. Why appendicitis moves, why diverticulitis happens where it happens, and the incredible sensor network that saves us from social embarrassment every single day.
It is so much more than just a tube. It hangs, it twists, it hides behind other organs, and it has these very specific relationships with the blood supply and nerves that dictate everything from surgery to simple stomach aches.
Okay, so let's start with the ID check. If you were a surgeon opening up an abdomen or just looking at a complex anatomy chart, how do you know you're looking at the large intestine and not the small intestine?
Well, the classic description is that it frames the small intestine like a picture frame.
Okay.
It runs up the right side, across the top, and down the left, surrounding all those jumbled loops of the small bowel.
Got it.
And structurally, it has a greater caliber. It's wider than the small intestine. But, you can't always rely on width alone because a distended small bowel can look huge.
So you need more definitive clues.
You do. There are 3 absolute giveaways, the telltale signs that tell you this is the colon, no question.
Okay, let's unpack these. The first one listed is the tenea coli.
Right. This is a crucial structural difference. In the small intestine, the longitudinal muscle, the muscle that runs the length of the tube, forms a complete continuous coat.
Like a full turtleneck sweater.
Exactly. It's a full coat. But in the large intestine, that longitudinal muscle is gathered into 3 distinct thick bands. These are the teneae.
So it's not a full coat. It's more like 3 suspenders running down the length of it.
That's a great way to put it. And the source actually names them, which is a nice detail for the anatomy buffs.
Oh, let's hear them.
You have the tenae libera, which is the free band. You can see it easily. Then the tenea omentalis, which is where the greater omentum, that fatty apron, attaches.
Okay.
And the tenea mesocolica, where the mesentery itself attaches. So they're also landmarks.
And these bands aren't just decorative stripes. They actually change the shape of the organ. Right. The source uses a really helpful analogy here involving a sleeve.
It's the perfect analogy. Think of a cloth sleeve where the elastic band inside is physically shorter than the cloth itself.
Right.
If you sew a short elastic into a long sleeve, what happens?
It bunches up. You get ruffles.
Precisely. The tenea coli are shorter than the gut tube itself. So they bunch the colon up, creating these sacculations or bulges.
Which leads directly to the second telltale sign.
It does. The haustra.
The haustra. These are the ruffles.
Yes.
Yeah.
If you look at a barium enema or an X-ray, the colon looks segmented, almost like a chain of clouds or a caterpillar. Those bulges are the haustra.
And if you were inside the colon looking at the wall, you'd see these ridges.
The semilunar folds, they're like little shelves between the pouches.
But unlike the valves in the small intestine, these folds don't go all the way around, do they?
No, that's a key point. They don't form a complete ring. They're just crescent-shaped shelves created by that bunching effect.
Interesting.
And it's also worth noting these haustra aren't everywhere. The cecum and the rectum, the start and the finish, are usually smooth. It's the middle sections, especially the transverse colon, where you see this dramatic sacculation.
So we have the tight bands, the tetenae, and the baggy pouches, the haustra. What is the third sign?
Number 3 are the omental appendices. You might also see them called appendices epiploicae.
Okay, what are those?
There are small pouches of peritoneum, the lining of the gut, and they're filled with fat. They just hang off the surface of the colon like little yellow teardrops.
You don't see these on the small intestine at all.
Never. If you see fat tags hanging off the tube, you are definitely looking at the large intestine. It's a dead giveaway.
The source notes that in obese individuals, these can get quite large.
They can. They accumulate fat just like the rest of the body. And they aren't distributed evenly either. You find tons of them on the sigmoid colon, but the rectum, none.
So another landmark for surgeons.
Another way surgeons orient themselves, absolutely.
Okay, so we've identified the beast. Now let's trace the path. We start in the lower right-hand corner of the abdomen, the cecum. The source calls it the blind pouch.
The cecum is the beginning. It sits in the right iliac fossa. Anatomically, it's actually the widest part of the large intestine.
So it's like a cul-de-sac.
A big cul-de-sac. And that width is clinically dangerous.
Dangerous how?
It comes down to physics.
Yeah.
Specifically, Laplace's law.
Oh, bring on the physics.
Simply put, Laplace's law states that the tension in the wall of a cylinder is proportional to its radius, because the cecum has the widest radius of the entire colon.
It's under the most mechanical stress.
Exactly. The wall tension is highest there.
So if there's a blockage somewhere else down the line?
Right. Let's say you have a tumor way down in the sigmoid colon blocking the exit. The pressure builds up backward through the whole system.
Okay.
But even though the blockage is meters away, the cecum, because it's the widest, is under the most wall tension. It is the most likely spot to blow out or perforate.
Wow. So it's the weak spot on the balloon, basically.
It is absolutely the weak spot on the balloon, a very important clinical principle.
That is terrifying, but it makes total sense mechanically. Now, entering the cecum, we have the connection from the small intestine, the ileocecal junction.
This is where the small intestine, the ileum, ends and the large intestine begins. And it's not just an open door. It acts as a specialized sphincter, the ileal papilla.
The bouncer.
The bouncer is a perfect term. Its job is crucial. The small intestine is relatively clean, relatively low in bacteria because its job is nutrient absorption.
Right.
The colon, however, is a bacterial fermenter. It is dirty in the microbiological sense. It has trillions of bacteria.
So the valve is there to stop backflow.
Exactly. The ileocecal valve prevents the reflux of that bacteria-laden colonic content back into the sterile small intestine.
So if that bouncer takes a break, you get problems.
You get huge problems. Bacterial overgrowth in the small intestine, which causes all sorts of nutritional issues and malabsorption.
Now, hanging right off the cecum is arguably the most famous part of the gut, for all the wrong reasons.
The appendix.
The appendix.
The vermiform appendix. Vermiform means worm-like.
I feel like the appendix gets a bad rap. We always hear it's a vestigial organ. It's useless. It's just a ticking time bomb waiting to go off.
Yeah, that's the common perception.
But the source material suggests it's not just dead weight.
No, it's definitely functional, especially when you are young. The wall is packed with aggregated lymphoid tissue. That's immune tissue.
So it's part of the immune system.
It is. It acts as a site of immune surveillance, sampling the bacteria passing by. Some theories even suggest it acts as a safe house for good bacteria.
A safe house.
Yeah, a place for beneficial gut flora to hide out during, say, a bad bout of diarrhea, so they can then emerge and repopulate the gut afterwards.
So it's a bunker for the good guys. That's fascinating. But when that security system goes wrong, appendicitis.
Right.
The source had some really interesting details on how surgeons actually find the appendix, because apparently it likes to wander.
It does wander. The appendix is like the tail on a dog. It can wag in any direction.
Yeah.
However, the base of the appendix, where it joins the cecum, is constant.
And there's a trick to finding it.
There is. Remember those 3 Tandiacolae bands we talked about?
The muscle stripes, yeah.
They all run the length of the colon and fuse together at exactly one spot, the base of the appendix. So if a surgeon is digging around and can't find it, they just follow the tanniae like a road map, and X marks the spot.
That's brilliant.
Yeah.
But the tip can be anywhere. The clock face analogy.
Right. Imagine the base is the center of a clock. The tip is most commonly retrocecil, meaning tucked up behind the cecum, which would be like the 11 or 12 o'clock position.
It could be anywhere else.
It could be pelvic, pointing down towards 6 o'clock. It can be pre-ileal or post-ileal, crossing in front of or behind the small intestine. It's highly variable.
And this positioning matters for the patient, doesn't it? Because if it's tucked behind the cecum, you might not feel the pain where you expect to.
Exactly. A retrosacral appendix might irritate the psoas muscle in the back, causing pain when you extend your hip, rather than the classic tummy pain. The presentation can be very confusing.
Speaking of pain, let's unpack the mechanism of appendicitis and how the pain moves. Because everyone knows the story. It starts in the middle and moves to the right. Why?
It starts with obstruction. The appendix is a narrow, blind-ended tube. If a phacolith, which is basically a little stone made of hardened feces, blocks the opening,
Little poop stone.
a little poop stone, exactly, it gets stuck. The appendix keeps secreting mucus but can't empty. It swells like a balloon.
So it's a blocked pipe that is alive.
Precisely. And as the pressure rises, the bacteria that live there normally start to overgrow. This distension triggers the visceral nerve fibers, specifically the T10 level.
Okay, T10.
Now, your brain also gets T10 signals from the skin around your umbilicus, your belly button. So the brain gets this distress signal from the appendix, but because it's vague, internal, visceral pain, the brain interprets it as somewhere in the middle, around the belly button.
So that's the vague, aching bellyache that you can't quite put your finger on.
That's the one. But as the appendix keeps swelling, it gets more and more inflamed. Eventually, that inflammation spreads from the appendix itself to the parietal peritoneum.
The lining of the abdominal wall?
Yes, the sensitive lining of the abdominal wall right next to it. And that lining has somatic innervation-precise pinpoint nerves.
Like the skin. You know exactly where it hurts.
Exactly. Suddenly, the brain says, oh, it's not the middle, it's right here in the right lower quadrant. That's when the pain migrates and becomes sharp and localized. That shift is the absolute hallmark of the diagnosis.
That is such a clear explanation. It's a shift from internal, vague signaling to external, don't touch me, inflammation.
That's it.
Okay, moving on from the appendix, we head to the ascending colon.
The ascending colon travels up the right side of your abdomen. Now, an important distinction here is that the ascending colon is retroperitoneal.
Okay, what does that mean in simple terms?
It means it's plastered to the back wall of the abdomen. It's fixed. It doesn't flop around on a leash, so to speak. It runs right in front of your right kidney and the iliac crest.
So it's locked in place until it hits the liver.
Correct. It hits the liver and has to take a sharp left turn. This is the right colic flexure, or more commonly, the hepatic flexure.
Hepatic for liver.
Exactly. It sits right under the liver shadow.
And then we enter the transverse colon. Now, this seems like the drama queen of the colon sections based on the description.
It certainly has the most freedom. Unlike the ascending colon, the transverse colon is suspended by a mesentery, the transverse mesocolon. It's like a hammock.
So it's not glued to the back wall.
Not at all. It's draped across the abdomen from right to left, and because it's not fixed, it's very mobile.
The source mentions it can sag.
It sags significantly. In some people, especially if they're standing up or if the colon is full, the transverse colon can dip all the way down into the pelvis, almost to the hip bones, before swinging back up to the left side.
Wow, that's a big U-shape.
A very big, highly variable U-shape.
Man.
Its length and position are different in almost everyone.
So it goes across or down and up to the left side where it hits the spleen.
And that's the next big landmark, the left colic flexure, or splenic flexure. This is a crucial spot.
Why crucial?
Well, a couple of reasons. First, it's actually higher up and more posterior, further back than the right flexure. It's tucked way up there.
Okay.
And it's attached to the diaphragm by a specific ligament called the phrenicocholic ligament.
Which also acts as a shelf.
Yes, the spleen actually sits on this ligament like it's resting on a shelf. This whole arrangement makes the angle at the splenic flexure very acute, a very sharp turn.
Which sounds like it could be a problem.
For endoscopists doing a colonoscopy, navigating the sharp, high, fixed turn can be one of the most difficult parts of the procedure. It's a real challenge.
So you've navigated the sagging hammock, turned the sharp corner at the spleen, and now you're heading down the descending colon.
Back to the left side. And, like the ascending colon, the descending colon is retroperitoneal.
Stuck to the back wall again.
Stuck to the back wall again, fixed. It's generally narrower than the cecum in the ascending colon, and it just travels down towards the pelvic brim.
And then things get twisty again. The sigmoid colon.
The sigmoid, S-shaped, hence the name.
Oh.
This connects the descending colon to the rectum. Now, structurally, this is another mobile section.
Oh, it's back on a leash.
Back on a leash. It has a long mesentery shaped like an inverted V.
And mobility comes with risks, right? We talked about the cecum twisting, but the sigmoid is the prime suspect for volvulus.
It is. A sigmoid volvulus is far more common. Think of the sigmoid as a loop of garden hose. If you have a long loop with a narrow base, which is exactly what the sigmoid mesocolon often provides, it can twist around its own base.
And that's bad.
Very bad. It cuts off the blood supply and blocks the tube completely. It's a surgical emergency.
And the source mentions this is common in certain groups. Chronic institutionalized patients.
Yes, often in elderly bedbound patients due to chronic constipation, and also in some populations in Africa and Asia with very high fiber diets, which can elongate the colon over time.
What does that look like on an X-ray?
It looks like a massive, air-filled coffee bean taking up the whole abdomen. It's a classic sign.
The other big issue with the sigmoid is diverticulosis. My dad has this. The pockets.
Diverticula, very, very common. And there's a reason they happen in the sigmoid. The sigmoid is the high-pressure zone of the colon.
Why is the pressure highest there?
Because it's the narrowest muscular part, and its job is to propel more solid stool into the rectum, so the muscle has to squeeze harder. If you strain a lot, say from a low-fiber diet causing constipation, the pressure builds up.
And something has to give.
Exactly. The inner lining of the gut, the mucosa, gets pushed out through the muscle wall. But it's not random.
There's a specific weak point.
There is. These pockets happen specifically where the blood vessels penetrate the muscular wall to feed the lining.
Why there?
Because the vessel entry point creates a natural hiatus, a small gap in the muscle. It's a gap in the armor. So when the pressure rises, the lining herniates right alongside the blood vessel.
Which would explain why diverticulosis can bleed so heavily.
Precisely. The neck of that little pocket is intimately tied to an artery.
It's like blowing a bubble through a keyhole.
A very messy, potentially dangerous bubble. If it gets blocked and infected, that's diverticulitis.
Let's shift gears to the plumbing, the blood supply. Because the colon is so big, it actually bridges two different embryological territories, and that affects which arteries feed it.
This is a critical concept for any surgeon. We have the midgut and the hindgut, which develop separately.
And have their own blood supply.
They do. The midgut, which includes the small intestine, cecum, ascending colon, and the first 2/3 of the transverse colon, is fed by the superior mesenteric artery, the SMA.
Okay, so that's the right side in the middle.
Correct. Its branches are the ileocolic, the right colic, and the middle colic arteries. They supply that whole territory.
And the rest.
Then you have the hindgut, the last third of the transverse colon, the descending sigmoid and upper rectum. That whole left side is fed by the inferior mesenteric artery, the IMA.
So two different main pipes, but they have to connect, right? You can't just have a dead end.
They do. They connect via a continuous arterial arcade that runs along the inner rim of the colon frame. It's often called the marginal artery of Drummond.
And that's an anastomosis.
A critical anastomosis, a connection. If the SMA gets blocked, blood can theoretically flow from the IMA backwards through this marginal artery to save the tissue.
Theoretically. I sense a but coming.
There is always a but in anatomy. The connection point, right around that splenic flexure we talked about, is known as Griffith's point.
The sharp corner again.
That corner again. It's a watershed area. The vessels here are often quite small or tenuous. In some people, the connection is very weak or even absent.
Oh, it's the weak link in the chain.
Precisely. If a patient has low blood pressure, say they're in shock or heart failure, this is the spot that dries up first. It's the furthest point from both main arteries.
And you get
ischemic colitis right there at the corner. The tissue starts to die from lack of blood flow.
It's the end of the line for both systems, so it's the most vulnerable. Is there any other backup?
Sometimes. About half of people have another potential connection called the arc of Rheelon, or the meandering mesenteric artery. It runs deeper in the mesentery as a more direct shortcut, but you can't rely on it being there.
Okay, what about the veins? The drainage? Does it follow the same pattern?
The venous drainage mostly mirrors the arteries, but there is a massive physiological distinction we need to make here. The veins from the colon, the superior and inferior mesenteric veins, drain into the portal vein.
Which goes to the liver.
Correct. Everything absorbed from your gut, all the blood, goes to the liver for processing first, except the very bottom.
The end of the line is different.
The distal rectum and anal canal drain into the internal iliac veins, which go directly to the inferior vena cava and the systemic circulation. They bypass the liver.
And this is the portosystemic anastomosis.
Yes. And this matters hugely in liver disease. If the liver is scarred, say from cirrhosis, and blood can't flow through it easily, the pressure backs up in the portal system.
Right.
That high-pressure blood looks for an escape route to the low-pressure systemic veins. One of those escape routes is the rectum. The veins there swell up massively, creating rectal varices.
So it's the plumbing backing up and finding the path of least resistance.
Exactly that.
While we are on the topic of plumbing, let's talk about the lymphatics. The source makes a point about cancer surgery here. It says surgeons have to remove a wedge. What does that mean?
This is the absolute core principle of oncologic surgery for colon cancer. lymph fluid and potentially cancer cells flows in a predictable hierarchy.
Okay.
It goes from the colon wall to epicolic nodes, which are right on the gut, then to paracolic nodes along the margin. From there, it goes to intermediate nodes along the arteries, and finally to the principal nodes at the root of the SMA or IMA.
So it follows the arteries back to the source.
Exactly. The lymphatics travel with the arteries. Because of this, you can't just cut out the tumor. You have to take the entire pie slice of mesentery that contains the feeding artery and all those levels of lymph nodes.
So you're not just removing the tube, you're removing the whole vascular and lymphatic tree that serves it.
The whole wedge. If you leave the nodes behind, you could be leaving the cancer behind. That's why the surgery is so extensive.
All right, we've made it down the left side through the sigmoid, and now we are at the business end, the rectum and the anal canal.
The rectum. And despite its name rectum means straight, it is definitely not straight.
Right.
It follows the curve of the sacrum, a big posterior curve, and it also has 3 lateral curves called the valves of Houston.
Houston, we have a curve.
We have 3 of them. These valves are really just folds of the rectal wall, and they probably help support the weight of the fecal matter so it doesn't all just sit directly on the anus.
Distributes the load.
Helps distribute the load, exactly. But surgically, the most important structure here is the mesorectum.
The fatty envelope.
Yes. The rectum is surrounded by this fatty cushion containing its lymph nodes and its blood vessels. In rectal cancer, the gold standard is TME, total mesorectal excision.
Okay.
This means surgeons have to find the correct plane and peel this entire fatty envelope off the pelvic wall, completely intact.
Like taking a letter out of a mailbox without crumpling the envelope.
Exactly. It's a very precise, sharp dissection. If they breach that envelope, cancer cells can spill back into the pelvis and cause a recurrence.
Wow. Now let's talk about the anal canal. The final 2 to 4 centimeters. This is where the magic happens regarding, well, not making a mess.
The mechanism of continence is brilliant. It's a multi-layered system. It involves 2 sphincters.
Right.
The internal anal sphincter is smooth muscle. It's a continuation of the circular muscle of the gut wall. It is completely involuntary.
You can't control it.
You cannot control it. Its resting state is closed. It provides most of your resting tone.
And the external anal sphincter.
That is skeletal muscle. It's voluntary. That is you. It's wrapped around the internal sphincter and controlled by somatic nerves. It's what you squeeze when you need to hold on.
Okay, so talk me through the sampling mechanism. So it blew my mind reading about it. The source calls it the rectoanal inhibitory reflex.
It is an incredibly sophisticated sensing system. So when the rectum fills with something, gas, liquid, or solid, it stretches.
Okay.
That stretch sends a reflex signal to the internal sphincter to relax. Just a little bit.
It opens the door a crack.
Just a crack. This allows the contents to descend slightly into the upper anal canal. Now, the lining of the anal canal is incredibly sensitive. It has sensory nerve endings that can distinguish between gas, fluid, and solid.
So your subconscious brain gets a report. Attention, contents are gaseous. Or, warning, contents are liquid.
Exactly. This is the sampling. Your brain gets this information without you even being aware of it. If it's just gas, you might subconsciously or consciously choose to let it pass.
And if it's solid?
If it's solid, your brain sends a powerful signal to the external sphincter to clamp down hard until you can find a socially appropriate place. The internal sphincter relaxes to test, but the external sphincter contracts to hold.
That is incredible. It's a double-lock system with a peephole.
It is a beautiful piece of neuroengineering. And the boundary line for all this sensation is the pectinate line, also called the dentate line.
The jagged line inside the canal.
It's the Great Divide. Above this line, the gut is lined by columnar epithelium, and it has visceral innervation. It doesn't feel sharp pain or cutting.
Okay.
So you can have internal hemorrhoids there, and they might bleed, but it rarely hurts.
But below the line?
Below the line, it's somatic innervation. It's lined with skin, basically, called anoderm. It is exquisitely sensitive to pain, touch, and temperature.
I see where this is going.
External hemorrhoids, or anal fissures, which are little tears, occur here. And as anyone who's had one knows, the pain is wildly disproportionate to the size of the lesion because of that incredible nerve density.
So, internal hemorrhoids, you see blood but don't feel much pain. External hemorrhoids, you feel a lot of pain. It's all about geography.
It is all about which side of the pectinate line you're on.
What about the anal cushions? The source mentions these are actually normal structures. I always thought hemorrhoid was the problem.
It's a confusing term. We often use the word hemorrhoids to mean a disease, but everyone has anal cushions. They are normal, specialized, submucosal vascular tissues.
And they have a job to do.
A very important job. They're located at 3, 7, and 11 o'clock positions, typically.
Why those specific spots?
It just corresponds to the terminal branches of the superior rectal artery, but functionally, they act like the washers in a tap. They swell with blood to create an airtight seal so that even liquid or gas doesn't leak out.
So they are necessary gaskets for fine-tuning continence.
They are. They only become hemorrhoids in the medical sense when they become engorged, slide down out of position, and start causing symptoms like bleeding or pain. But the cushions themselves are vital.
Let's zoom in now. We've done the macro anatomy. Let's look at the microstructure. Section 7. How does the wall of the large intestine compare to the small intestine?
The biggest difference you'd see under a microscope is the surface. The small intestine has those little finger-like projections to maximize absorption area.
Yeah.
The large intestine has no villi. The surface is flat, smooth.
But it has pits.
Deep pits, yes. They're called crypts of Lieberkühn. These are intestinal glands, and they're lined primarily with a cell type called goblet cells.
The mucus factory.
They're the mucus factories, and the further you go down the colon from the cecum to the rectum, the more and more goblet cells you find. By the time you get to the rectum, the lining is almost entirely goblet cells.
Why so much mucus?
Lubrication. Remember, the colon's main job, besides housing bacteria, is water absorption. As the stool travels from the cecum to the rectum, it gets progressively drier and harder.
So you need slime to keep it moving.
You need a lot of slime. It prevents damage to the wall, and yes, it keeps things moving. It's a slip and slide for solids.
And the cells turn over pretty fast too, right?
Incredibly fast. There are stem cells at the very base of these crypts. They constantly divide, and their daughter cells migrate up to the surface. The entire lining of your colon is renewed every few days.
Wow. Now, how does it actually move? The motility is different too. It's not just a constant conveyor belt.
No, not at all. Most of the time, the colon is doing something called segmentation. These are churning movements that don't really push things forward much.
What's their purpose then?
They just mix the contents back and forth to ensure the water gets absorbed. It keeps the stool in contact with the wall, like kneading dough.
It's just processing.
Just processing. But then, a few times a day.
Mass movement.
A mass movement. These are large, powerful, sweeping contractions that propel a huge amount of colonic content forward, sometimes over long distances.
And that's often trumped by eating.
Yes, it's called the gastrocolic reflex. When you fill your stomach with a meal, a hormonal and neural signal goes to the colon to basically clear the decks and make room. A large wave sweeps through the transverse and descending colon.
Pushing a large amount of stool into the rectum all at once.
Yes, and that sudden distension of the rectum is what triggers that strong urge to defecate.
Which is why many people feel the urge to go after breakfast.
Exactly. The stomach wakes up the colon.
Let's talk about the control center for all this. The nerves. We have the second brain in the gut.
We do. You have the enteric nervous system embedded in the wall. The Meissner's and Auerbach's plexuses, they handle all the local traffic, the segmentation, the secretions.
But there's a higher level of control.
There's an override from the central nervous system, the sympathetic and parasympathetic systems.
Fight or flight versus rest and digest.
Classic. Sympathetic fibers from the T10 to L2 level of the spinal cord generally inhibit movement and close the sphincters. If you were running from a tiger, you don't want to poop. It shuts down the gut.
Makes sense. And parasympathetic.
Promotes motility, rest and digest. But here's a cool anatomical detail that ties back to what we said earlier. The parasympathetic supply is split.
Split how?
The first half of the gut, the midgut derivative ascending, and most of the transverse colon, is supplied by the vagus nerve, the wanderer from the brain.
And the second half?
The second half, the hindgut derivative, the descending colon, sigmoid, and rectum, is supplied by the pelvic splanchnic nerves arising from the sacral spinal cord S2, S3, and S4.
So the brain controls the start and the sacrum controls the finish.
Effectively, yes. It perfectly reflects that dual embryological origin again.
So to synthesize all this, we've traveled 1.5 meters. We've seen the valves, the blood supply watersheds, the incredible sensing mechanisms. What does it all mean?
It means the large intestine is an organ of exquisite adaptation. It protects us from bacteria with the appendix and the ileosacral valve. It reclaims liters of water every day so we don't dehydrate.
Right.
It stores waste so we aren't constantly expelling it. And it has a complex sensory discrimination system to maintain social hygiene. It's a multitasker.
It really connects the dots on so many common ailments. Why appendicitis starts vague and gets sharp. Why older people in shock might get ischemic colitis at that specific corner near the spleen.
Exactly.
Why hemorrhoids hurt or don't hurt, depending on which side of a line they're on.
It transforms anatomy from a list of parts into a logic puzzle. Once you understand why the blood supply routes, the nerve distributions, the physics, the clinical symptoms make perfect sense.
I want to end on a final thought from the source material regarding the puborectalis muscle. We touch on the sphincters, but this muscle is part of the pelvic floor, and it's maybe the most important part of this whole story.
The puborectalis, it's a sling. It's a U-shaped muscle that loops around the back of the rectum and pulls it forward towards the pubic bone.
So it creates an angle.
It creates a sharp angle, the anorectal angle between the rectum and the anal canal. It literally creates a kink in the hose.
The kink in the hose.
Exactly. And that kink is actually the primary mechanism of continence for solid stool. The sphincters are important for fine-tuning, for gas and liquid, but the puborectalis keeps the door shut by simple geometry.
So how do you kink it?
When you sit down to defecate, and this works even better in a squatting position, that muscle relaxes. The angle straightens out, the kink is gone, and gravity can do its work.
The source calls it arguably one of the most important muscles for maintaining social civilization.
I would agree 100%. Without the puborectalis and that anorectal angle, we would not be able to function in society the way we do. It's a subconscious hero working 24/7.
So the next time you feel that little gurgle in your lower left quadrant, or you're just sitting comfortably without worrying about an accident, give a little mental nod to your large intestine. Let's do some heavy lifting.
The final edit, a masterpiece of plumbing and engineering.
It really is. Now, I want to invite you, the listener, to just think about that intricate engineering occurring subconsciously right now in your own abdomen. It's happening while you drive, while you work, while you listen to this.
And never stops.
Thanks for diving in with us. It's deeper than you think.
Always.
Catch you on the next deep dive.